Hello and welcome to a special interview for The Wire. The Director General of the World Health Organization has said that the worst is yet to come. So how bad can things actually become? And with India almost touching 650,000 cases, increasing at over 20,000 a day, and with the peak nowhere in sight, what steps does the Indian government now need to take? Those are two key issues I shall raise today with the Chief Scientist of the World Health Organization and the former Director General of the Indian Council of Medical Research, Swaminathan. Dr. Swaminathan, let's start with the global picture. I'll come to the situation facing India after that. WHO reports show that almost 40% of the world cases happened in June alone. Over the last 1 week, the rate of increase seems to have jumped from 160 cases a day to over 200,000 a day. And now, understandably, the Director General of the World Health Organization has said the worst is yet to come. Do you have any sense of how bad things could become?
So we don't have a crystal ball, Karan. And first of all, thank you very much for this conversation. What we've seen and what we've understood about this virus is what is guiding us. And WHO then guides member states and countries by putting out what is the state of the science at the moment and what we think could happen and why countries need to act in a timely manner to stop that from happening. We've seen now, understand this virus a lot better, and we know that it is highly transmissible. And we also know the kinds of conditions and the kinds of environments where this thrives. And we've seen successful efforts to actually curb the transmission and curb the spread of this virus. Many countries have been successful at that. And so as we've been learning and as we've seen how this is playing out, and we've seen this virus sweeping across the world, affecting different parts and regions and continents at different times since the beginning of the year. We're at a stage now where we know what are the public health measures that work. They are not easy, they're difficult.
But before we come to the public health measures that work, can you give me a sense of how bad it could become? Because your Director General has said the worst is yet to come. How bad could things be?
So the reason for the statement is the fact that the majority of the world's population is still susceptible to this virus, okay? Over 90%. From all the studies that have been done, we know that over 90% of people in most areas and in some places, much higher numbers are still susceptible. And as long as the virus has a susceptible host, a human being, it will spread, it will continue to go. And we've seen exponential growth happen where the conditions are right. And that is why the warning that the worst is yet to come. And it can, unless we intervene. So the worst is yet to come unless we, human beings, intervene against the virus. So there are two players here.
Absolutely. I want to pick up on that point that you made, that as yet 90% of the world's population remains susceptible to the virus. Now, the figure that we have as of today of the global number of people infected is almost 11.2 million. But that's only the officially reported cases. How many more would exist globally that are unreported and perhaps undetected? The CDC in the United States, as you know, said a couple of days ago that for every reported case in USA, there were at least 10 that were unreported. What would be the tally globally?
We don't know. As you said, we only know the cases that were tested and that have been counted. And usually these are people who report to the health system because they are unwell, at least at the beginning of the pandemic, that's the way it was. As contact tracing has increased and improved across the world, we've started finding more asymptomatic people as well. But even then, this 10.5 million is only the tip of the iceberg. From the studies that have been done where countries have looked at antibody tests in their populations to estimate the number of people who've been exposed to this virus, in many of these countries, 5 to 10% of their citizens, of the population of that area, have antibodies, which means they've been exposed. And the average number of infected to those who presented with illness is anywhere between 8 to 10 times higher to even 20 times higher in some places. So I think you could guess that the true number of infected people may be 10 times more.
But even as you said, possibly 20 times more.
It could be. And what we need are more well-conducted studies. We know of studies happening in at least 90 countries now. But these need to be large, well-conducted seroepidemiological studies, which will help us to really understand, where this infection is.
That's very clear, Dr. Swaminathan. You really explained to an audience in India how large the scale could be when the Director General says the worst is yet to come. The number of people who could be affected but are not detected or reported could possibly be 20 times what we think is the official figure. Let's, in that light and in that context, talk about some of the areas of concern. And let's start with the United States, which has not only the world's biggest number of cases by far and the largest number of deaths. But now the cases are growing at over 55,000 a day, and I'm told that 37 of the 50 states within the United States are seeing rising numbers. How do you read the picture in the United States?
Again, we know what this virus will do, how it can be controlled and contained, and when it will begin to spread. It needs human-to-human contact to spread. It spreads mainly by droplet transmission, which means you need close contact for prolonged periods of time. And the moment it finds that environment, and if the virus is already in that community, it is going to spread. And what we've seen is that when they've been in the situation of opening up, and people haven't followed the guidelines that have been laid down, and people have congregated in large numbers, and people have been in closed environments, in close proximity to each other. It's been interesting to see that majority of infections in the last wave has been among young people. So the median age now is in the early 30s in the US outbreak. And this reflects the fact that these young people are up and about, either going to work or for entertainment and social reasons, getting together and fueling this spread. So this is entirely expected and will be seen in any country where the virus is still present and if the right conditions come about.
A second area of concern are the countries of Latin America, the Mexicos, the Chiles, the Brazils, and the Perus, as well as, of course, India. Now, these are countries where we have no idea when the peak will come. It's still very far away. But these are also countries that do not have a robust healthcare system. How worried are you that the virus is now racing ahead in this part of the world?
In fact, Karan, I would say that this pandemic has exposed weaknesses and gaps in all countries' healthcare systems. And the countries, the high-income countries, which we all consider to have excellent public health care systems, including universal health coverage and good tertiary care systems, were the ones who got overwhelmed and saw a huge number of deaths. In fact, it's the poorer countries, the middle and lower income countries, I think, that have relied on their public health response that have actually done better, at least till now. And so there was also a recent assessment which looked at how well countries are prepared for outbreaks and pandemics. You've heard of the international health regulations. There's a way of actually scoring countries based on their preparedness to respond, detect, and prevent epidemics. There was no correlation between how high countries scored on this preparedness index and how they've actually performed when hit by a pandemic. So I think every country has faced this challenge. Some countries have done better than others, but I think the one common thread has been a good public health system, and even that has been overwhelmed in some countries.
It's a very interesting point you make, that whereas the rich countries have healthcare systems that have been overwhelmed, the poorer up till now have handled it or fared better. In that context, let me ask you about Africa. At the moment, Africa looks like a continent that is relatively not that badly affected. As of today, Africa as a whole has some 450,000 cases. It has just under 11,000 deaths. But can Africa remain an unaffected or less affected continent? Or is this a crisis that's simply waiting to happen?
Well, one would certainly hope that it remains less affected because Africa faces so many other challenges, both in terms of incomes, livelihoods, poverty, and multitude of health conditions, What Africa did, many countries in Africa did, was to respond very, very early. They put in place measures early in the outbreak, and even took very stringent measures like lockdowns, and that I think really helped keep the cases down. There is, of course, the issue of testing and whether there's adequate testing. In many countries of Africa, at the beginning of this outbreak, they did not have laboratories that could do these molecular tests. And within a few weeks, the WHO had helped and supported almost all the countries in Africa today, which are able to do testing, but probably that has to improve even more. The other thing is Africa has had, again, experience because of their huge burden of communicable diseases like tuberculosis, HIV, malaria, and other neglected. They have invested in public health. They've invested in primary healthcare systems and in surveillance and response to diseases like Ebola fever and Lassa. So actually, there's more experience in Africa. There's more community engagement. There's more community outreach and community workers and nurses that are trained to do the kind of work that's needed now. So this is where I think the basics of the system, even though they may lack in tertiary health facilities and sophisticated and could get overwhelmed if you had a huge number of people needing critical care, hopefully the basics that they have in place would help to keep them.
Once again, that's very interesting. You're opening our eyes to the fact that Africa has a lot of experience handling cases like Ebola and Lassa, which achieved epidemic, if not pandemic status, and their experience is standing them in good stead. Let me come to Europe, because as you know, countries all over the world are steadily and progressively relaxing their lockdown, and Europe is clearly in the lead in doing so. Soon we will have, in fact, flights and train journeys and car journeys between European countries. Are you worried that you might now start seeing surges of the infection in Europe, where earlier people thought they had it under control? After all, such surges have happened in South Korea, they've happened in Germany recently, they've happened in China. Are you worried that Europe may be rushing to open up just too fast?
I think most countries in Europe have taken a calibrated and stepwise approach to opening. As you know, many of them put in place extremely stringent lockdowns, and people in general also obeyed, the instructions of the government and really stayed indoors. Now they're opening up, some faster than others, but most of them in a calibrated way. And again, it is to be expected as conditions are relaxed that there will be more infections. I think what countries have done is to put in place systems to detect and respond quickly to those clusters, whether it's a cluster in a nightclub or a bar, or whether it happens, within some other kind of a office setting, or, we've seen in Germany, the meat packing factories had a huge cluster of cases. So we know exactly where these things will happen. And they were able to go in there very quickly, test all the workers, isolate them, the families, and contain it within that space. South Korea did the same. China recently had an outbreak in Beijing. They did the same. They did a huge amount of testing in the neighborhoods around that market where the infections were detected. So I think this kind of preparation is needed before lockdowns are lifted, where you're able to go in, test, detect, isolate, track contacts, quarantine them, shut down that cluster before it actually expands and spreads in the.
One country that defied the wisdom of the world and didn't lock down is Sweden. All its Scandinavian neighbors did. Today I discover that Sweden has 21 times more deaths than Norway, 16 times more deaths than Finland, 9 times more deaths than Denmark. And in fact, if you look at overall cases, Sweden has 2.5 times more cases than the other 3 Scandinavian countries together. So looking back, would you say Sweden made a mistake in not locking down?
Look, every country had to make choices and had to make decisions, very, very difficult decisions. And every country chose a particular path. And Sweden chose a path because they have the capacity within their health system. They also have social support, social care for the entire population. The population is thinly spread and able to isolate, and generally has very high trust in government and follows government instructions even without, imposing very strict measures. And so they chose the way of more voluntary restriction. It's not that they didn't put in place. Yes, they've seen more cases, they've seen more deaths compared to their neighbors. But we will have to see in the long run. They've now actually taken some measures and their death rates have started coming. In the long run, I think, again, we learn, every few weeks we learn a little bit more about this. In hindsight, we're always wiser and we say we should have made this choice or that choice. But their death rate has started to come down and they have to come to.
Let me at this point, Dr. Swaminathan, raise two sets of results that are beginning to concern people, particularly here in India. You alluded to one of them a moment ago. Up till now, it's been the belief that young people and therefore countries with young populations are best able to withstand the coronavirus. But the ICMR, you used to be Director General of it until 2017, released figures at the end of May that suggest that 48.8% of COVID deaths in India are people under 60. And as you pointed out yourself, Vice President Pence has said that over 50% of recent cases in America are people under 35. Does this suggest that the advantage a young person or a youthful population had is now questionable?
So there are two aspects to this question, Karan. The first is you mentioned that 48% of deaths are in people under 60 in India. Well, 90% of the population is under 60 in India. And so you've got to see where the bulk of the infections are happening. We have a more youthful population. Are they completely safe and immune from the infection? We know that the older an individual, the higher the risk of complications. But we also know that even young people have comorbidities. In the US, obesity is a big comorbidity in young people, and they are the ones who are actually getting the complications. In India, we know that diabetes and hypertension starts at a relatively younger age. In 30s and 40s, people get these diseases, which we know again are risk factors for complications. Smoking is also a risk factor. And so it's not that young people are completely safe. They're relatively, yes, but if you have one of these pre-existing illnesses or others which we don't know about as yet, we don't know the impact of malnutrition, we don't know the impact of other stressful situations, life situations, and how that impacts, you can get into complications and end up in the hospital in a serious condition. And so we shouldn't get complacent about the fact that because the majority of the population are young, we can freely allow the infection to run through the population. I think that's a dangerous assumption.
Another area of concern is the disproportionate number of people of Indian origin in the United Kingdom who seem to have died of COVID-19. I know that the British government has instituted a specific inquiry to look into this matter, and I know also that they've imposed localized lockdowns on cities like Leicester, which have a large Indian population. But are you concerned at the WHO about this, or do you think this is explained by the age profile of that population, by their comorbidities, and perhaps also by their socio-economic conditions of life?
No, we're very concerned about this, Karan, and again, we need to understand more the vulnerabilities of some of these groups. As you said, in Britain, it has ethnic minorities. In the United States, in New York, we saw that the Latino population and the African American population suffered disproportionately more severe illnesses and deaths compared to the white population. And so in every country, I think this pandemic has also exposed the inequities and the vulnerabilities of certain groups. And this probably is different from country to country. We need to look at genetic factors that may be making people more susceptible, but I think even more important are the economic and social and environmental factors, things like housing, access to water sanitation, access to healthcare. These are the things probably which are playing a bigger role than genetic susceptibility in my view. And we've seen in India in urban slums, for example. If you look at the hotspots in India, they're all in the big cities, in mega cities, and in the cities where there are huge density of population living in slum-like conditions. And that again is an environment where this virus spreads very quickly. So those are the vulnerable people.
Let me at this point come to two particular medicines. I'll start with hydroxychloroquine. I see that the WHO has dropped it from your solidarity trials where you were looking into the therapeutic value of particular medicines. You clearly believe hydroxychloroquine has no therapeutic value. India, on the other hand, believes it has prophylactic value. Do you think that hydroxychloroquine can protect healthcare workers in the front line from catching COVID-19?
So as you rightly said, we recently did a pooled analysis of all the hydroxychloroquine data from trials that were treating people in hospitals. So people with COVID-19 with moderate or severe illness. And I think it's now conclusive that it has no impact on reducing mortality or sickness in those people who are hospitalized. Now, I think jury is still open on whether it has an impact in prevention. And I think the final word on that will only be said when the results of the ongoing clinical trials are ready. And that will take a couple of months more. So till then, I think it's still an open question whether hydroxychloroquine prevents, but we know that it's not useful in treatment. And it's unfortunate because we were hoping some of these repurposed drugs like lopinavir, ritonavir is another drug that's used to treat HIV, but that again doesn't seem to have any impact.
The second medicine I want to discuss with you is remdesivir. It's been officially announced that America has bought up the entire world supply for the month of July of remdesivir, and as a result, Gilead has postponed generic manufacturing of the drug in India. Is it, in the present circumstances, fitting for any one country, no matter how rich it is, to seek to buy up the entire world supply of a drug which is critical?
WHO believes, as you know, at the very heart of our philosophy is equitable access to populations between countries and within countries. And so I hope that there's a little more of global solidarity when it comes to the distribution of vaccines and drugs for COVID, because they are going to be in short supply initially, whether it's a new vaccine that's developed or whether it's a drug like remdesivir. And we need to think about, we are discussing with member states now on what an equitable allocation framework could look like. What can we agree on something? And of course, countries need to agree. This is where the political commitment will be very, very important. And bodies like the G20 plus and the G77, etc., should really debate and discuss how do we address these questions. As far as remdesivir, again, clinical trials are ongoing. There's still no concrete proof that it reduces mortality, though it does reduce the duration of hospitalization, perhaps severity of illness. So we're trying to finish the solidarity trial to understand which subgroup of patients benefit so that they can be targeted. But I'm also glad to see a large number of generic manufacturers who have been given voluntary licenses by Gilead. And I understand a couple of them are already starting to produce and market the drug in India.
The generic manufacturers in India who were given license by Gilead to manufacture remdesivir in this country have been suspended for a while because America has acquired all rights for the month of July. So the generic manufacturing in India has been postponed. It hasn't started as it was meant to have. It will happen after a lag. But as you say, this is an issue that you hope the world will sort out politically, so that there is a fair distribution of drugs rather than any one country that can afford it monopolizing them. Finally, before I take a break and come to India, I want to talk to you about an issue that I suppose matters to everyone in the world, the search for a vaccine. We already know that Oxford, AstraZeneca and Moderna are making good strides. Recently, we were told that BioNTech and Pfizer have also got vaccines that have proven to some extent their safety and also proven that they can create a sizable number of antibodies. Is there a sense in which we could end up being closer to a vaccine than most people realize? Or are these newspaper reports a little misleading?
So what's very positive about the vaccine landscape is the fact that we have a very robust pipeline. We have over 150 candidates in preclinical development and 17 of them or even 18 of them into clinical trials, into phase 1, 2, or 3. Of course, only a couple of them are in phase 3. Are entering phase 3 in July, the month of July. And so we will know by the end of the year results from several of these clinical trials. Now, vaccine development is a risky business. Just because there's a vaccine that's gone into phase 1, 2, etc., we can't be sure that it succeeds unless we see the large phase 3 results, which look at both efficacy, that's the protection that it offers, as well as the safety. And so it's good to see candidates passing phase 1, going into phase 2, which is encouraging, but we know that only 10 or 20% of them are likely to be successful. What's good is that there are several different platforms. So you have DNA and RNA viruses, you have protein viruses, you have the viral vectored viruses. So there are new and old platforms that are being tested. So the hope is a couple of them, but let's be very realistic in our expectations. Till we see the results, we don't know if it's successful. And if it's successful, then manufacturing needs to be scaled up to billions of dollars. And that takes a little bit of time. So perhaps in early 2021, we may have, if we're lucky, if things go well, some doses of 1 or 2 of these vaccines that are now in clinical trials. It's only towards the end of 2021 that we can expect to see sufficient volumes to start immunizing larger groups of people. Countries are thinking about who should be the first receivers of limited doses of vaccine. So again, it's being discussed. Should it be healthcare workers, other frontline workers, other vulnerable people? So that needs to be done simultaneously.
Can I, Dr. Swaminathan, pick you up on those critical dates? Because to us in India at this moment, they have great meaning. As you said, if we are lucky, we could see the first vaccine in early 2021, and it will only be towards the end of 2021 that we will see sufficient volumes. Now, on the 2nd of July, that's just 2 days ago, your successor as Director General of the Indian Council of Medical Research, Balram Bhargav, announced that an Indian vaccine, which is apparently still at preclinical stage, will be fast-tracked through its clinical stages. And this announcement said, and I'm quoting, "It is envisaged to launch the vaccine for public health use latest by 15th August 2020. That's literally 6 weeks from now. What has the WHO been officially told by the Indian government about this vaccine?
So we've had quite a lot of discussions with all the Indian manufacturers, and in fact, there are 7 companies that we are aware of that are developing vaccines, some in collaboration with developers outside India, and quite a few local indigenous vaccine efforts, which is excellent to see. And the DBT and the ICMR have been working very closely with these companies. And the WHO, we had a video conference with them where we discussed where they are, what support they might need.
Have you been officially briefed about this particular vaccine that Dr. Bhargav says should be available for public use on the 15th of August, 6 weeks' time? I mean, has either the ICMR or the government officially briefed the WHO about this vaccine?
So I was talking about this video conference we had, and Bharat Biotech was one of the companies that was present in that video conference, but so were 6 others. And we were very encouraged to see the kind of work that's going on. And I also heard that another company, Cadila, has also been given permission to launch their phase 1 trials. Now we have to understand phase 1 is just the first in human tests. And I understand the plans of Bharat Biotech are to use 2 or 3 different doses of this vaccine. There are 2 doses which need to be given to these volunteers. They need to be followed very closely for at least the next 28, but longer days. Blood draws will be done. Safety has to be established. So by August, I think you will start seeing some results of the phase 1 trial. Again, if everything goes well and according to plan, it's important to follow the ethical and scientific guidelines and principles. These are global guidelines. The ICMR has their own ethics standards and guidelines for clinical trials. And it's very, very important to stick to that, Karan, because I think it's not just the credibility of the scientific organization and vaccine developers, but we need regulators and we need the people to believe that any vaccine that's made available for public use has gone through that very rigorous process. And WHO has been saying repeatedly, yes, you can fast track. There are ways of doing things more efficiently and faster, but not by compromising on these scientific and ethical principles.
Dr. Swaminathan, you said a very important thing. You said that Bharat Biotech had indicated to you that they expected to complete phase 1 by August. Phase 1 is then followed by phase 2. That's followed by phase 3. Phase 3 could be possibly the longest of the 3 phases.
Yes.
So there's a long time before the Bharat Biotech vaccine will be ready for use by patients. And yet, Dr. Bhargav in his letter said, and I'm quoting him again, it is envisaged to launch the vaccine for public health use latest by 15th August 2020. Somewhere there seems to be a huge mismatch, if not an absolute mistake.
No, I'm sure Dr. Bhargav will clarify what he said because I can't speak for him. But the fact is, clinical trials take time. And we just said, you go to phase 1, then you go to phase 2, which is several hundred people. You look for safety. You also start looking for immunogenicity. That's, how well the immune system responds. And then you go to phase 3. And we are recommending phase 3 should be done in at least 20 to 30,000 people so that you get a very good idea of how well it protects as well as the safety of the vaccine. And so that takes time. Phase 3s usually take years. But again, if you do it efficiently, if you do it at multiple sites, you're well organized about it, you could do phase 3 and you do it in high risk populations where there's a high incidence of infection. So the WHO has been putting out guidance actually on how to do vaccine trials, right from animal studies to the laboratory assays. It's important to standardize the design of the trials, what are the endpoints that should be measured, all that's available for developers and for governments to use.
As you said, Dr. Swaminathan, it is important to follow the ethical and scientific guidelines. People need to have confidence that the vaccine development has gone through the rigorous process that is required. Phase 3, as you said, should perhaps involve 20 to 30,000 people. That usually takes years, although it could be compressed. Given all of that, and I'm simply repeating your words back to you, do you believe that India could have a vaccine that patients can use in 41, 42 days time on the 15th of August?
No, it cannot be put into people in such a quick period of time. It has to go through the clinical trials, and I understand phase 1 has not yet started. So the timelines have to be realistically, I think, projected. And maybe you have to ask Dr. Bhargav, but I think he might have meant that the phase 1 might be completed in August, and it might be ready for the larger.
But again, I don't want to interrupt you. It's quite possible he meant phase 1 will be completed in August, but that's not what his letter said. His letter said, and I'm quoting, it is envisaged to launch the vaccine for public health use latest by 15th August 2020. And it's created, not surprisingly, enormous consternation, not just in media circles, but in scientific circles. I mean, there are people in the newspapers quoted today to say that this statement will make India the laughing stock of the scientific community abroad, because it seems to claim we'll have a vaccine in 41 days.
As you said, I'm from ICMR, okay? And I know, and I've done clinical trials myself. And I know very well the scientific community in India. We have also a very active civil society and people who raise questions all the time about the ethics of things and about transparency and so on. So it's a very robust environment, really. And one can't get away, very easily with doing things which are not publicly then have to be defended. And I also know our manufacturers and developers. We have strong scientific institutions. We have excellent manufacturers and developers. Bharat Biotech has developed vaccines before. So have many of the other companies. The Serum Institute of India, supplies a huge percentage of the world's children's vaccines. And as I said, there are 7 companies that are developing vaccines. There's Cadila, there's Syngene. There are many others. And so I think what we need to do now is to focus on the science.
Absolutely.
And provide opportunities for all of these companies to do the kind of trials that are needed. India has the resources, the manpower, the infrastructure, the capacity, and the infection rate at the moment to do these trials. So we have to support and encourage each one of these candidates to go through rigorous testing.
But you've done something very important today. You've reassured the Indian audience watching you, not just lay people, but also scientists and specialists, that the process, ethical and scientific, of developing a vaccine must be rigorously pursued. As you said, you've learned from Bharat Biotech that phase one hasn't even started. And although you haven't said it explicitly yourself, it's quite clear that we cannot expect a vaccine in 41 days' time. I won't push you any further because I know you are speaking as the chief scientist of the WHO, and you don't want to involve yourself in Indian controversies, and it would be wrong to drag you into them either. Let me take a quick break. I then want to talk to you in a very limited amount of time about what strategies you think India should be pursuing. After all, we are growing now at over 22,000 a day. We're touching 650,000, and the peak is nowhere in sight. But first, a quick little break. Welcome back to a special interview for The Wire. My guest is the Chief Scientist of the World Health Organization and the former Director General of the Indian Council of Medical Research, Swaminathan. Dr. Swaminathan, let's talk about India. In India, the number of cases is just short of 650,000. It's growing by over 20,000 a day, and the peak is nowhere near in sight. What are the steps you believe the Indian government should be taking?
Yes, it's a very difficult time for governments, I think, because of this need to balance between keeping this virus under control and still being able to provide, livelihoods to people, especially for a country like India, tremendously challenging with the population, the heterogeneity, and the differences between the different states and the capacities that we have. I would say, looking ahead, first of all, I think we have to treat this as a longer term situation. This is not going to end anytime soon. The virus is going to be with us for the foreseeable future. And so we need to think about how we're going to sort of create a new normal, so to speak. It has to be an all of society response. That's another important element. So there's the government response, but there's also what individuals and communities need to do. It cannot be only the government that does everything. So again, all of society, all of government response. What are the areas we need to focus on? 3 or 4 key things. I think you want to try and reduce the transmission as much as possible. You want to try and keep this infection at as low a level as possible. Not get rid of it completely. That's probably not possible. But to bring the curve down, flatten it, keep it as low as possible, where you're in a position where you're comfortable, you're able to manage at that level of ongoing infection in the community. It's not overwhelming your health systems. You're able to provide care for all the other things that people need health care, and you're able to deal with COVID. The second goal should be to keep death rates as low as possible, reduce mortality, avoidable deaths. And that can be done if there is a lot of testing, early detection of cases, good primary care, which means that the majority of people are going to recover. I think we have to keep reminding people, 80% of people who get this infection have very mild or moderate symptoms and they recover. And it's a 15 to 20% who need hospital care, they need oxygen, and a small minority who then progress. So detect early, monitor them, make sure they don't go into those severe stages, have protocols, clinical protocols at each stage, make sure that there's a triaging system and a system to send people from one level of care to another so that you try and minimize deaths. And the third thing I would say is to look at India as a whole. And in fact, maybe this should even be the first point, is to focus on data and have strategies that are context specific and driven by local data. We need granular data. A mega city like Mumbai cannot have the same strategy as a rural area in Chhattisgarh or in Orissa. And so we need to form strategies based on local transmission patterns, on local risk factors, on local healthcare capacities. And India has all of that. We have good epidemiologists. We have an excellent, in many states, very good public healthcare system. But I want to come back to the public healthcare. We have scientists. We have manufacturing. We have private sector. We have corporates. We have all the elements. We need a comprehensive plan where everybody plays a role.
Can I pick you up on 2 points that you stressed, particularly when you were making your second point? The need to test and detect, and the need to then ensure good quality primary healthcare so that people are cured and treated and don't die. Let me take them up one by one. At the moment, India is testing 6,900 per million. That compares to 116,000 for Spain, 149,000 for UK, 92,000 for Italy. Now our population is 10 or 12 times greater than those European countries. So what level of testing do you think India needs to achieve so that you would be able to say this is adequate?
So again, the level of testing depends on where you are with the epidemic, and it's very heartening to see that India started with very low testing rates, and today is testing, I think, over 2.5 lakh people a month, and I think the capacity to grow is still there. And they've been able to, I understand now, all the materials are made, the reagents are made in India. So this is very good that we're self-sufficient in diagnostic testing. Now there are some criteria you can use, some benchmarks. And the benchmarks are really about the test positivity rates. So, of course, there should be a minimum amount of testing in the community. But if your test positivity rates are under 5%, then that gives you an indication that you're testing probably adequate numbers of people. So today, I think you see this scenario where in some areas of the country, probably it's much less than 5%. But in many areas, particularly in the cities, we have test positivity rates of 20, 30% or even higher, which shows that enough testing is not being done. So again, as I said, it needs to be driven by the data. We need indicators. The WHO has a set of indicators that countries can use and that every state should use to report on. Things like test volume, but also things like test positivity rate and things like how many contacts are being traced for every positive case, how many contacts are being quarantined, and what is the death rate in the...
On that point you made, that if your test positivity rate is under 5%, it shows you're testing adequately. I'm saying this from memory, so I might be wrong, but I think the Indian national test positivity rate, until a few days ago, had risen to around 10%. It's probably come down by a percent since then. So clearly, that is a sign India needs to test a lot more. But this reminds me of what your Director General said somewhere around the 16th, 17th of March. At a press conference, Dr. Tedros said the answer was, his words were, test, test, test. And the very next day in response, Dr. Bhargav in India at a press conference said, this statement does not apply to India. It applies to Europe. It's inappropriate for India. You get the feeling that India was slow to test, reluctant to test. It's only now that it's picking up to better levels of testing.
All countries, most countries were slow to begin testing. And this also was a factor in this was the global supply chains. You know, there were many countries were importing test kits, and then there was a complete breakdown of global supply chains. So I think where we are today is good. And I think I've seen the recent statements from the ICMR saying encouraging testing, removing restrictions, and asking people to expand testing, asking states to expand testing. I see this as a very encouraging step. And of course, we should do more. We can do even more. But again, it has to be, I think there needs to be like some kind of a common dashboard that every state is using so that at the national level, at the state level, you can see what's going on. Support states which aren't doing enough, which need to do more, and also have a better analysis of the data that's coming out of this huge amount of testing that we're doing.
My last question, and it picks up on that second point that you made, that after testing, the need was a good healthcare system, a good primary care system, so that people could be cured. Now, you understand the Indian healthcare system probably better than anyone. If our infection levels get to 2 or 300 million, as some projections suggest could be the case in September, can the Indian healthcare system handle it? Or will it be overwhelmed?
Well, again, this is something that we can do something about now before we get to the point where things are overwhelming. We've seen this happen in a few places, in a few cities, but it's been handled well, I think. So, if you see what's happened in Dharavi, they went in there with a very strategic, well thought out plan and were able to achieve a significant reduction in the number of cases. So the one thing we need to remember is we cannot give up. We cannot be fatalistic and say that, oh, this is going to happen, we're going to be overwhelmed. There are things we can do now. We should
Can
do
you,
now.
can you
And
say
it's
what those things are? Can you say what those things are?
yes, those things are a very good public health strategy and a response, because again, it's very simple. What needs to be done is to test as much as possible, especially in those areas where there's a lot of transmission going on, to try to track, isolate all positive cases, to try to track as many contacts as possible and quarantine them, to improve healthcare facilities. Simple things like oxygen can make a big difference and should be available in primary healthcare settings. We also know now that there's transmission possible from people who are not symptomatic or not coming to hospitals because they don't feel sick. And this is where I go back to the individual responsibility and the community's responsibility. Every individual has to follow precautions and has to do what the government is telling them to do, like wearing a mask when you go out into crowded settings, by making sure you follow respiratory etiquette, by maintaining physical distance wherever possible, by washing your hands. These are things that individuals need to do. Also, offices and shops and commercial setups also need to look at their own environments to try and make it as safe as possible. Educational institutions will have to do that. And finally, I would like to say that communication is very, very important. I think public trust is extremely important, and public trust is earned through good communication of both risks and what people should do and at what stage they should be doing and what realistically is to be expected.
As a media man, I'm particularly happy to hear you stress the importance of communication. But I want to point out to you that the official press conferences that used to be held by the Ministry of Health or the ICMR haven't happened since the 11th of June. There hasn't been a single press conference since that day. More importantly, at that last press conference, they said they had done a serological survey of hotspots, but that information hasn't been made available to us either. So do you get the feeling that the Indian government, the Indian system simply isn't communicating enough?
So communication is important, and I've seen several state governments do a good job of communicating, and it's important for political leadership to communicate because they are the ones who can influence the masses. They have the mass following, people listen to them. It's also important for the technocrats, the scientists, and the public health officials to communicate the details. And as an example, the WHO has done 74 press conferences over the last couple of months. I think in the beginning, for the first 2 months, we were doing almost daily press conferences. Now we do it 3 times a week. We operate through social media. So there are many ways of communication other than press conferences. You can use radio, television, social media, etc., to communicate messages. And I think I would like to say that we need to involve our behavioral and social scientists, as well as scientists who are in institutions outside the healthcare system. We have excellent geneticists, we have molecular people who can contribute to this fight. And the social and behavioral scientists are the ones who tell us what behavior change communication is all about.
Dr. Swaminathan, you have just, without intending to do so, given us a list of the people who should be speaking, but who in India have been completely silent since the 24th of March when the lockdown began. You said it's important for political leadership to communicate. We barely ever hear from ministers in Britain and in Europe. Ministers hold press conferences daily. Not here. Here, bureaucrats from the health ministry do. You say it's important for technocrats and public health officials to communicate. With the exception of 1 or 2 doctors who are involved with the government, no one else wants to give interviews. I hope and pray that the system is listening to you and follows your advice about the need to communicate. But I want to end by thanking you for this interview. You've given us an awful lot of time. You shared with us your thinking about what's happening internationally as well as about what you think needs to be done here at home in India. Many thanks. Take care. Stay safe.
Thank you.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.